failure for the same. So dental caries is an irreversible microbial disease of the calcified tissues of the teeth, characterized by demineralization of the inorganic portion and destruction of the organic portion of the tooth, which often leads to cavitation. So it is irreversible. That means once caries occurs, its manifestations will be lifelong. It cannot go back to a normal tooth structure. Of course, there are certain conditions which are known as very, very incipient caries, where remineralization is possible. But mostly, dental caries will leave its marks as a cavity. So it is irreversible. It is microbial. That means it is caused by some infection. Many times question is asked to you, which is the most common bacterial infection of the oral cavity? And you start thinking about tuberculosis, actinomycosis, but the most common bacterial infection is nothing but your dental caries. There are a number of theories of pathogenesis of dental caries. Acidogenic proteolytic, the most common one being the acidogenic theory, which is put forth by W.D. Miller, commonly called as Miller's chemicoparasitic theory. And the other one, which is given by Gottlieb, is the proteolytic theory. So you should know about all these theories, mainly the two, acidogenic and proteolytic, in detail. Acidogenic theory, or the Miller's chemicoparasitic theory, it says that caries is not caused by a single factor. It is multifactorial. There are a lot of things which are there, which play a role in its causation. Mainly the microorganisms, but the carbohydrates, acids, as well as dental plaque are equally important. So this theory says that the acids which are produced from the carbohydrates and which are produced by the microorganisms which are there in the dental plaque ultimately will cause demineralization of the inorganic portion, and then the caries will progress inside towards the dentine. Whereas the second theory, that is the proteolytic theories, it says that there are certain organic pathways, namely the enamel lamellae, through which the microorganisms go into the inside portion of the tooth, and the dentine is destroyed first, followed by the demineralization. So which are the microorganisms which are actually playing a role in the causation of dental caries? The two chief microorganisms, one is Streptococcus mutans. Though all 5 types of Streptococcus are important, but Streptococcus mutans is required for caries initiation, and lactobacilli are there for caries progression. Actinomyces are important and early colonizers in root caries. Then caries is classified depending upon its progression as acute and chronic dental caries, depending upon its location as pit and fissure caries and smooth surface caries. Smooth surface caries can occur on the enamel, or it can also occur on the cementum. Depending upon whether the lesion is a new one, it is called as primary or virgin caries, or whether it is occurring around the margins of a restoration, then it is called as secondary or recurrent caries. Acute dental caries, fast progression of the lesion, so involvement of the pulp is faster. The two main types of acute dental caries are rampant caries and nursing bottle caries. Rampant caries affects almost all teeth in the dentition. Teeth which are normally immune to the caries or surfaces which are not generally affected by caries are also involved in rampant caries. Even the lower anteriors are involved. And rampant caries generally occurs in adolescents and young adults, maybe due to their faulty eating habits, maybe their faulty cleaning habits. So some people are prone for this rampant caries. A special type of rampant caries is nursing bottle syndrome affecting infants, attributed to prolonged use of nursing bottle and breastfeeding, especially at night. So the commonly affected teeth are the maxillary incisors and the first molars. And very peculiar feature is that the mandibular incisors are not affected because, as you can see in the picture, they are covered or protected by the tongue. So when the parents of a child with this nursing bottle syndrome come to your practice, you have to counsel them for taking proper hygienic measures after the feeding process. Pit and fissure caries, seen mainly on the occlusal surfaces, affects even the buccal and lingual surfaces. It is seen as a brownish black discoloration, as you can see here. This is a pit and fissure caries here. Okay, you can see only a small portion of the tooth which is affected, but if you can see this area which is bluish white, isn't it? Why this is appearing? That means when you drill this tooth with your instrument, you will land up in a big cavity, and that is because the caries has undermined the inside dentine. That is because of the lateral spread of caries at the dentino-enamel junction. So pit and fissure caries progresses faster, involves a great amount of tooth surface, even though from the surface, from the top, it looks as if only a part of the tooth has been involved. So it's a very characteristic feature of pit and fissure caries. Smooth surface caries, proximal surfaces are more affected without involvement of the occlusal pits. Generally, it is preceded by formation of microbial or dental plaque. Now, both pit and fissure and smooth surface caries can progress. Of course, pit and fissure caries progresses faster, but on some occasions, this caries can even get arrested. So which are the occasions when the caries can get arrested? When the pit and fissure caries forms a large open carious lesion, the opposing tooth, the sharp cusp of the opposing tooth, that can grind that carious lesion, that can polish that carious lesion, leading to an ivory-like polished appearance, which is called as hibernation of dentine. There the caries gets arrested. Sometimes on the proximal surface of a tooth, when there are two teeth which are affected by proximal caries, the one which is affected maximum is extracted. Automatically, the other proximal surface becomes self-cleansing, and in that case, the proximal caries also can get arrested. Both these lesions appear as brownish black discolorations, and as you know, the caries will not progress further. There will not be any catch there. Recurrent caries, caries which is formed on margins of restoration. Sometimes inadvertently, the entire carious lesion is not removed, or sometimes there is an inadequate extension of the original restoration, which favors debris retention. At times, there can be poor adaptation of the filling material to the cavity, which produces leaky margin. As you can see here, you can see this old amalgam restoration, and you can see this brownish discoloration down below. The restoration has got little bit separated. That's a property of silver, no more used nowadays. But amalgam restorations do separate away from the tooth surface, producing leaky margin, and that can lead to recurrent caries. Histopathology of caries, enamel caries, cemental caries, but I have only listed some points on dentinal caries because they are little peculiar. So when the caries process enters the dentine, the bacteria which go into the dentinal tubules first are called as, they are the leaders, they are called as pioneer bacteria. What do? They cause decalcification of the walls of the dentinal tubules. The dentinal tubular walls becomes little swollen, which causes a beaded appearance. Some of these dentinal tubules which are getting destroyed, broken down, they coalesce and they form liquefaction areas, which are called as liquefaction foci of Miller. As you know that the dentinal tubules always have lateral branches. So whenever the caries spreads along the lateral branches of the dentinal tubules, it leads to formation of transverse clefts, which are seen perpendicular to the dentinal tubules. And the most important clinical aspect of it is that carious dentine can be peeled away along these transverse clefts. So the chief histopathological features of dentinal tubules being beaded appearance of the dentinal tubules loaded with bacteria, liquefaction foci of Miller, and transverse clefts. So how do we prevent dental caries? There are mechanical measures, there are chemical measures, there are nutritional measures. Some mechanical measures can be done by you. For example, you can do a regular dental prophylaxis, or you can use pit and fissure sealants. And most of the mechanical measures have to be undertaken by the patients, a proper toothbrushing, rinsing, flossing, etc. Chemical measures Communal water fluoridation is the most important thing, but in your dental office, you can do topical fluoride application using sodium fluoride, stannous fluoride, acidulated phosphate fluoride, or ask the patient to use fluoridated dentifrices. Moving on to the sequela of dental caries. What happens when the carious process extends to the next tissue of the tooth, that is a pulp? So let's see what are the disorders of pulp and periapical diseases. Pulp is a delicate connective tissue which responds to bacterial infection or any other irritant by inflammation, that is pulpitis. That means it is a connective tissue. So how different it is from the other connective tissues? Yes, it is different. It is slightly disadvantageous, this difference. Pulp is enclosed within hard dentinal walls, which precludes its excessive swelling. So pulp cannot swell up as normal connective tissue. So whenever there is an inflammation in the pulp, it will cause fast destruction of pulp in the form of necrosis. The second reason being, blood vessels which are supplying the pulp, they enter through tiny apical foramen. So these blood vessels, when they get thrombosed, when they get compressed by the inflammatory exudate in the pulp dies. And there is no collateral circulation. So hard-bound dentinal walls, tiny apical foramen, and no collateral circulation are things which are going against pulp in case of pulpitis. Etiology of pulpal diseases. Most commonly it occurs as a sequela of dental caries. Sometimes bacteria can be there in the blood-borne bacteria. They can be there, they can accumulate at sites of inflammation, especially the periapical inflammation or the periodontal inflammation, that can cause anachorotic pulpitis, but mostly pulpitis occurs as a sequela of dental caries. However, pulp can undergo death because of certain physical reasons such as blow during fight or sports, pathological wear such as atresion, abrasion, erosion, cracked tooth syndrome. Some of the iatrogenic procedures can also cause irritation to the pulp. Heat from the cavity preparation without coolant, irritating medicaments which are applied close to the pulp can also result in pulpitis. Pulpal diseases are classified actually as pulpitis, pulp necrosis, pulp degeneration, but most of the times what we consider is as pulpitis, which will be focal or total, acute or chronic, open or closed. What is open and closed? Depending upon whether the pulp, involved pulp, it has communication with the oral environment, it is classified as open pulpitis. When there is no communication, it is called as closed pulpitis. So how does this pulpitis start? It starts with focal reversible pulpitis, also called as pulp hyperemia. Reversible, that means the condition can be reversed. Okay, patients generally complain of sensitivity to cold. What is more important is removal of stain, stimulus, pain disappears, which does not happen when it goes to the acute pulpitis stage. So in acute pulpitis, there is severe lancinating type of pain, especially on taking hot drinks and in lying down position. Patient complains of a low pain reaction threshold that is seen, of course, on the electric pulp vitality tester. And the pain of acute pulpitis is poorly localized. What do you mean by that? The patient may not be able to tell you that this particular tooth is paining. Patient may show you an area which is paining, or patient may also tell that the pain is referred to the other jaw. Why this is happening? The pain of pulpitis is poorly localized because pulp is not represented individually in the cerebral cortex. This is how you distinguish pulpal pain from periodontal pain. In case of periapical or periodontal pain, the patient will be able to localize, you also will be able to know which tooth is paining. However, pain of pulpitis is poorly localized. Chronic pulpitis, all the signs and symptoms are less. There's a mild dull ache. A special form of chronic pulpitis is chronic open hyperplastic pulpitis, which is also called as pulp polyp, as you can see here. You can see a pinkish globule which is coming out from the dentinal cavity, and this is called as an excessive exuberant proliferation. It is especially seen in children and young adults due to high tissue resistance and large open apical foramina. Children have teeth which have got open apices, so there's a lot of vascular supply to the pulp, and they have a high tissue resistance. So pulp, instead of dying, it proliferates out and it comes out as a polyp. This pulp polyp should be clinically distinguished from gingival or gum polyp. You should see where the origin is, because gingival polyp or gum polyp also comes into a carious open cavity from the proximal area. So gum polyp has to be distinguished from pulp polyp by knowing its origin. After pulpitis, the infection will definitely spread only in one direction. Once the pulp is infected, the infection cannot come out. It will spread only in one direction through the root canal into the periapical lesion, causing apical periodontitis. The other periapical lesions can be periapical abscess, which can be acute or chronic. Sometimes it can get localized, and it can cause a periapical granuloma, which can also lead to a periodontal cyst, periapical cyst. This particular infection from the periapical region may travel to the bone, leading to osteomyelitis, or it may travel through the tissue spaces, causing cellulitis or facial abscess. So then we come to the diseases of periapical region. The 4 important diseases that you remember are acute apical periodontitis, periapical granuloma, periapical cyst, and periapical abscess. Periapical granuloma is a localized mass of granulation tissue consisting of proliferating fibroblasts, endothelial cells, blood capillaries with chronic inflammatory cells. Periapical cyst, I will not be talking because Dr. Palaskar madam has already explained you in detail about that. Radicular cyst, or also called as infected dental cyst, it's a true cyst lined by epithelium derived from cellulose of Malassez. The third lesion is periapical abscess, also called as dentoalveolar abscess. It's an acute or a chronic suppurative process. Patient will complain that the tooth is extremely painful. There can be a slight extrusion from this socket. On radiograph, all these are seen as radiolucencies around the apex of the tooth. But what is peculiar about a granuloma and a cyst is usually that it is surrounded by a sclerotic, well-corticated border, whereas an abscess is a hazy radiolucency. Many times in the beginning, when the abscess is actually forming, because of the rapidity of its process, there is no radiographic evidence of its presence. Later on, it is seen as a hazy radiolucency. So even from a radiograph, you should be able to say whether it is a granuloma, cyst, or an abscess. Next important lesion here in this periapical diseases, of course, is osteomyelitis, which is inflammation of bone and bone marrow. Commonly occurs as a complication of dental infection, but it is also seen in trauma, accidents, gunshot wounds, radiation damage, or due to certain systemic diseases. Histopathological picture is showing you a dead bone. It is called a sequestrum, and that bone will show you empty lacunae and a very irregular border. And these you can actually in the scalloped margins of this dead bone, you can see multinucleated giant cells, which are osteoclasts, and an inflammatory infiltrate in the marrow. So how does this osteomyelitis occur? It is because it is, of course, bacterial in origin. However, the main reason for osteomyelitis is ischemic necrosis. That means whatever blood vessels are present in the marrow spaces, they get thrombosed, they get compressed by the inflammatory exudate, and that leads to death of the bone. So ischemic necrosis is the important pathogenesis point from pathogenesis point of view for osteomyelitis. Osteomyelitis is classified as bacterial, chemical, and osteoradionecrosis. Bacterial can be acute and chronic. It can be acute specific or acute non-specific. Chronic osteomyelitis, which we normally see, it can be due to certain diseases such as tuberculosis, syphilis, which is syphilitic gamma is osteomyelitis, or it can also occur because of actinomycosis. The osteomyelitis resulting from dental infection is chronic non-specific. When it is focal, it is called as condensing osteitis. When it is diffuse, it is chronic diffuse sclerosing osteomyelitis. A special type of chronic osteomyelitis is Garre's osteomyelitis, which we should know in detail. There are certain chemical causes, yellow phosphorus, mercury, bismuth, arsenic poisoning, and as you already know, osteoradionecrosis because of radiation therapy, the bone dies, or because of bisphosphonate treatment, what occurs is osteoradionecrosis. So Garre's osteomyelitis, again, the important terminology which you must know is chronic osteomyelitis with proliferative periostitis. This is generally seen with a mandibular first molar or second molar tooth with a long-standing infection, dental caries, where the infection is spread to the bone, and that leads to thickening of the periosteum and peripheral reactive bone formation. And as you can see in the picture, which is indicated by the arrows, you can see that there is a duplication of the cortical plate appearance, and that is the appearance is called as onion skin appearance, a typical appearance on a radiograph for Garre's osteomyelitis. So when you take a radiograph of such patients, you are going to see this particular onion skin appearance because of peripheral reactive bone formation. Coming to my next topic, diseases of periodontium. I will not be discussing this in detail because you are going to learn this in your final year as substantive